Welcome to this PCR webinar, DCB Digital Crosstalk. And this is the first of two that we do today on the topic of drug-coated balloons. And it's actually number 3 and 4 of a series we have started several weeks ago, where we talked about drug-coated balloons as a first choice for patients with de novo lesions, pros and cons with Xavier Escanet and Bruno Scheller, and of course in-stent restenosis with Fernando Alfonso and Azim Latib. Those two are available online, as will these from today will be. Today we talk about practice pattern. We have two expert users in the studio, Professor Luca Testa from Milan and Dr. Sandeep Basavarajaya from Birmingham in England. So we get England and Italy, and later today we look into Asia and the US with Bernardo Cortese. Before we begin, just remember and a reminder, you can participate. We don't have a poll today, but you can ask questions and we will try to answer these in between the presentations. I've shown this slide before, so this time not animated, just as a reminder of where we are with drug-coated balloons. You can see there the first DCB, as we see them today, was done in 2006, and it came from a more than 10-year evaluation of these drugs in local drug delivery, with local drug delivery systems. But now we've got drug-coated balloons with a CE mark in 2014, and this year, very topical, an indication in the United States for in-stent restenosis. And we have guidelines that go back and forth in Europe. We can discuss that in a moment. But that's where we are today. In clinical practice, and that's the topic of today, there's a wide variation. Leave nothing behind is a mantra. We don't have scaffolds anymore, so this is what we can do if we don't want to stent. The evidence is pro and con. It's difficult to really identify a clear cut strategy there. Cost implications are certainly there. There's a large range of DCB systems, and the guidelines, again, it's a question to discuss. These are the currently available DCBs, and they have largely, we can talk about paclitaxel-coated balloons and sirolimus-coated balloons. The learning objectives today are largely to review practice patterns of expert DCB users in Europe. I've talked to both just before. They use DCBs in about 30% of their cases. We will discuss the role of DCB in treating diffuse disease and all other applications, and the effectiveness of DCB use in various clinical scenarios. This webinar today is sponsored by an unrestricted grant of Concept Medical. This is what we will have today. My introduction is now done. Luca Testa will talk about his practice, then Sandeep about his practice in England. We'll have time for question and answers, and then we have two cases in point, really, where the drug-coated balloons play a major role in a winning strategy. We have an hour, which has now started, and I hand over to Luca Testa for the first talk. What is it you're doing in Milan, Luca?
Okay. Professor Bambach, thank you very much for the opportunity to discuss what I'm doing in Milan, in Italy. And Well, actually, I tried, as much as possible to summarize in just one slide some of the concepts that we will be discussing for sure. And as you can see here, I also tried to highlight the proportions of what I'm doing. So just let me confirm that I'm using DCBs on a large scale in my practice, which is around 1/3 of all the procedures I'm doing. Obviously, in different clinical scenarios, but also in different anatomical scenarios, as you can see here. So, needless to say that the majority of the cases are done in terms of ISR treatment, SVD, small vessel disease treatment, but also side branches. But obviously there are some other, let's say, new kids on the block, like CTO, distal segments, calcified fibrotic lesion, and definitely the hybrid approach was taking place over the years in our practice, in my practice especially. So I'm going to go through a few cases. Let's start with something like a combination of a calcified fibrotic lesion in HBR patient, talking about coronary angiography of a RCA, as you can see, in a diabetic patient in dialysis with a recent non-STEMI. As you can see, there is a lesion, that tight lesion, calcified and fibrotic in the proximal RCA. So the idea was not to use DES in this case in order to minimize the duration of dual antiplatelet therapy. And then after lesion preparation with the rotablator, I basically decided to see whether the ischemia was still there. And then the physiology confirmed it was not there. So actually I felt, actually free to not to place another stent or not to do any additional, let's say, metallic maneuvers. So semi-compliant balloon, and then a DCB, and as you can see here on the right, you see the final result, which was quite nice, I have to say, and then it was consistent with the strategy I started with. Second case is a combination of more complex situation with CTO, distal, and not occluded segment, and the hybrid approach, which means combination of DES and DCB. So obviously a very long procedure, many technicalities here, but for the sake of time, I just go through all this to show you that at some point, after all these complex maneuvers, I managed to place a stent in the proximal segment, but then the distal portion was not okay. So I decided, okay, we need to do something for this gentleman. And then I used a DCB for long inflation, as you can see here. And then that was the final result, which was honestly truly encouraging. So an additional case was basically a side branch case in a large vessel. So left main distal. We don't talk about bifurcation today, but just wanted to show you that after placing the two stents that I was talking about, then the ramus looked, kind of in trouble, I would say. So I decided not to use any additional method. So I ended up this procedure using, after the pot, of course, and based on IVUS, I used a DCB to the ramus, as you can see here, with a very interesting final results. Obviously, this procedure was guided by the IVUS. And again, CTO and small vessel in the long occluded segment of RCA with homolateral PDA and contralateral distal perfusion. So I negotiated this cap and I managed to cross into the PDA. And then actually I placed the first stent in the segment where the occlusion was placed, and I was kind of happy. But after imaging, again, I realized that the proximal segment, but also distal segment, were not okay. So again, a hybrid strategy, an additional stent proximally and a DCB distally. So I left this procedure, and then I was honestly very happy not to use an additional stent in a small vessel. Again, the last case I want to show you is a large vessel, an HBR. I'm talking about a 75 years old lady with a misdiagnosed anterior STEMI and apical thrombus leading to triple therapy at the end. So in the view of reducing as much as possible the duration of dual antiplatelet therapy, I started this procedure thinking about not placing any stent. So as you can see, multiple pre-dilatation with a 275 DCB for a distal circ, multiple pre-dilatation with a balloon with non-compliant, and then cutting for the proximal segment, followed by 3x20 DCB for a very interesting, I would say, almost stent-like final results. So back to the initial slide. These are my practice, of course, and clearly this is because I'm actually getting more experience and confidence in using these technologies. Obviously, a class effect does not exist. Obviously, all these indications should be based on data, on literature we are now producing. So this is, again, my practice. And I will conclude saying that there is a growing interest, of course, around the DCB technologies, and the most recent guidelines have somewhat downgraded the use of DCBs. However, the interventional community continues to search for the correct implementation into the daily practice. And I thank you all for that.
Luca, thank you. Before we move on, there is one direct question already from the audience, so that should be encouraged, really. It's simple. It's Ruzgar Ahmed. Getting rid of calcification is compulsory before deploying a DCB? Question mark.
Well,
so how about preparation? Yeah?
Oh, big question mark. Mm-hmm. Obviously, I mean, the presence of calcium as a matter of concern, because we need to work on a lesion preparation anyhow. Either with the use of DES or DCB, definitely you need to debulk if it's needed, or at least create some cracks. There are some theories concerning the reduced absorption of the drug in the presence of calcium. However, we don't have conclusive data. What I can say, this is what I do in my practice, I carefully prepare the lesion, and then if the angiographic result is acceptable, then I use the DCB. But if it's not, I keep going with the lesion preparation. This is absolutely crucial in order to minimize the risk of acute thrombosis, but also to increase the chances of long-term patency.
I'm sure we'll come back to that, to preparation and what is considered an acceptable result. Now's the time to look into Sandeep's practice in the Heartlands Hospital in Birmingham.
Thank you very much, Professor Bomback, and it's a great honor to be part of this webinar, and I'm extremely grateful for this. So in this session, I would like to share my practice in England. So let's ask a question. Which lesions can be treated with DCB? The answer is any lesion can be treated with DCB after optimal lesion preparation. But the question is that the right approach? My answer to that is no. And why do I say that? Because we cannot recommend DCB in all lesions. One, there is no evidence to support DCB in all comers, especially in large vessels. The current generation drug-eluting stents have excellent clinical outcome, especially in non-complex lesions. And finally, DCB angioplasty has a learning curve. So lesion preparation, when to accept, when to go for bailout stenting. So if you don't do the procedure properly, then you will have a bad outcome, which will dent your confidence and also give a bad name to the technology. So according to me, which lesions and patients I use DCB? So for me, the classic indication is in-stent restenosis because the stent has already failed, and the last thing you want to do is put another layer of metal. But the most important aspect of treating ISR is the use of intravascular imaging because you have to understand the mechanism of stent failure. It could be a mechanical issue or it could be a new-atherosclerosis. So I'll show you this case. This is an ISR of a circumflex stent. The operator had used 3mm stent and had taken up with a 3.25mm NC balloon. Now, if I didn't have the imaging, I would have probably taken a 3mm or maybe 3.5 to prepare this ISR. But when I did the IVUS, and I was amazed, the stent was grossly undersized and underexpanded. And more importantly, the distal reference of this vessel was almost 4mm, and proximally it was even 4.5 or 5mm. So this gave me a confidence to take a large balloon, so 4.0 and 4.5 at high pressures. And then I corrected the mechanical issue. You could see the pre, it's grossly undersized and underexpanded, and in the post, there is good expansion. And of course, we checked there was no stent fracture. And once we were happy with that, we used a long DCB, and we had an excellent result. This was done almost 7 years ago, and patient hasn't come back. So this case highlights the importance of intravascular imaging. How about de novo lesions? I'm not sure that we can beat a DES with DCB in such lesions. A non-calcified proximal LAD, left main, big stent. The stent failure is very, very, very small. And we have seen in the REC cage-free trial that the DCBs did not meet the non-inferiority with stents. But when they looked at the sub-analysis, the small vessels were non-inferior, but not so in the large vessels. We have enough data in the literature to support the use of DCB in small vessels. Most of them have shown non-inferiority, and one of them, in fact, has shown superiority over stents. For me, the treatment challenges are this. These are lesions which gives me nightmare because they are diffusely diseased, calcified, diabetic, renal failure patients. Surgeons won't take these patients on. And if you do end up treating with stents, you'll end up getting a full metal jacket. And we know what happens to full metal jacket over time. They will come back with failure. So we know that the risk factor for restenosis are small vessels, long lesions, systemic factors like diabetes, renal failure, and calcification. So DCB should strongly be considered in diffuse small vessel disease. And the aim of DCB angioplasty is to minimize the stent length and to avoid stents when they're not desired. And we should avoid giving such pictures going forward in the future. I would like to show a case of a de novo diffuse LAD subtotally occluded vessel, which was treated with a too long DCB after lesion preparation, and we put a stent in the proximal vessel. And we had a final result like this. So you could see the STEMI3 flow, but if you look at the stented segment and the DCB segment, you feel the DCB segment has not done very well, and you get that urge of putting stents, but we refrained. And patient had an angiography follow-up a year later where he had come with chest pain, and you could see the LAD is much bigger than what it was post-procedure. Of course, now the problem is an RCA CTO. And if you compare the post-procedure and the follow-up, you can appreciate the remodeling of the vessel. The other place I find DCB useful is a bifurcation, especially 001 bifurcation, where it's difficult to land a stent right at the ostium. Either you'll miss it or it'll come into the main branch. Whereas the DCB, you have the luxury of bringing the balloon back into the main branch. So I'll show you a case. This is an ostial occlusion of a PDA, acute MI patient. So obviously we crossed and established a TIMI3 flow with balloon dilatation. And when we looked at the artery more closely, there was a significant size mismatch. So we wanted to avoid a stent. So we took a long DCB, and look at this DCB. This has come all the way into the main branch. We don't have to worry about that because we're not leaving anything behind. And when I injected the contrast, you see the contrast goes into the PLV, but not into the PDA, which means PDA is nicely blocked with the balloon, enhancing the drug absorption. So this was the final result we had. And patient obviously was discharged, and he came back 3 months later for a check angiogram because he had some disease in the left system, and you could see the artery looks very nice, much bigger, and possibly remodeled. Another place I find is these complex bifurcations. So this is a calcified LAD diagonal, diabetic, again, renal failure patient. And how would you treat this? If you want to treat with the conventional bifurcation techniques, you probably will do a culotte in the top branch, maybe a decay crush in the bottom. But what we did in this case was we used DCB in both diagonals, and we put a stent in the main branch, and we had a result like this. Now it looks obviously not optimal, especially the second diagonal. There's a type B dissection, but the flow is TIMI3, and patient was completely asymptomatic with no chest pain or ECG changes. So we accepted this, and 10 days later he came back because we had to do his right coronary artery, and we took the image of the left system, and we were amazed that the dissection was getting better, and more importantly, the flow was preserved, and patient was completely asymptomatic. The last indication obviously is high bleeding risk patients, especially patients waiting for cancer surgery where they can't take DAPT beyond a month. I use DCB irrespective of the vessel size. So in conclusion, stenting should not be the default choice in all lesions. We should be avoiding full metal jackets, especially in small vessels and LAD. DCBs are good alternative when stents are not desired, and they should be considered as complementary to drug-eluting stents, not as a competitor. So in my practice, I use in ISR, small vessels, diffuse lesions, side branches, and high bleeding risk patients. Thank you.
Excellent. Thank you very much, Sandeep and Luca. So we've got time to discuss all this. It is, as we said, this is a view into expert users. We could call them power users. You're probably doing more DCB than the average interventional cardiologist. Our practice in London would be slightly different. We do use DCBs and distal LADs, and bifurcations seem to be one of the really up and coming and obvious indications for us. So first question to Luca. None of this is guideline, right?
Yeah. Well, actually,
is there a problem that we're not guideline aligned, or do we get more and more evidence to underline our practice before we go into the practical issues of doing it?
Let's say that, well, clearly the fact that the guidelines have downgraded the use of DCBs, as a matter of fact, is a problem in terms of what we should be doing according to the literature. Nevertheless, I mean, the practice, the use, the implementation of DCBs has been always, let's say, kind of different compared to the available literature. And what I mean is that in the process of creating the evidence needed, we are using it in order to establish some important understanding, in order to establish practice, in order to really get to know the technologies that we are talking about. Obviously, as you've shown before, there are multiple players available in the market, and as a matter of fact, all of them are different. So we should be actually doing specific trials, specific studies, which is obviously unlikely. Nevertheless, the application of this technology has a huge potential. So from one side, guidelines giving us indication, but obviously the practice went way beyond the guidelines. And is it correct? Is it fair? I think so. For just one important goal, to deliver the best up-to-date procedure for our patients.
For the patients, exactly. So we keep getting questions, and I'll weave those into what I wanted to ask Sandeep in the first place. You showed a stent-like result, and you showed a not stent-like result in this big RCA. Ever since we do the stenting, we seem to want perfect results, and we've spent decades on trying to find ways to achieve that with preparation and post-dilatation, high-pressure dilatation, IVUS guiding. And now all of a sudden we're back to the days when I started doing angioplasty with plain old balloon angioplasty, where you leave a dissection behind, where you leave 70%, well, 20% restenosis or the stenosis behind, where you have recoil. There's two questions about recoil here. What is acceptable and what is not, and how do you make that decision? Is that experience, or are there criteria? Sandeep.
So thank you. So the current criteria is up to 30% recoil is acceptable.
30%?
30% recoil.
Okay. And do you measure that with QCA, or is that just...
It's a QCA. I mean, it's eyeballing angiographically.
Yeah.
But the most important aspect is that if you have a recoil after the lesion preparation, then you should not be using DCB till you address the recoil. Mm-hmm. So for example, if I start with an NC balloon, and if I get a good expansion of the balloon with no recoil after that, that lesion is ready for DCB. Mm-hmm. But if it recoils, or if the balloon is not expanding, that is when we need to use specialized balloon like scoring or a cutting balloon. Mm-hmm. But if you keep having recoil, there's no harm in putting a stent back in. So there are times I have to accept that I cannot prepare this lesion for a DCB, and I'll go with a stent because balloons are expanding, but it keeps recoiling because of the volume of calcium or fibrosis. Mm-hmm. The final point is that, as you said, our eyes are expected to see a stent-like result, and which you will not always get in DCB. In some cases you get, like you saw in some of my cases, but some cases you don't. But I think we should wait for the artery to remodel, because acute results are never the indicator for a good outcome in the long term. So it's more of a recoil of more than 30%, or if there's a flow-limiting dissection, that's when you put a stent in. Otherwise, you can accept it and leave it. Okay. With time, you'll appreciate it. Or
I think yes, probably there's a lot of experience needed to say it's safe to leave this alone. We certainly made, in the old balloon days, we made that experience, but sometimes learned the hard way what is not acceptable. Luca, if you dilate a normal high-grade lesion in an artery with a balloon, the mechanism of it getting a larger lumen is a dissection. So by nature of the game, you will have a dissection. Whether you see it angiographically as a big one or not, fact is you have a dissection. How much dissection are you happy to leave alone? What are your criteria to leave a...
Well, it's a rather complex question, yeah. But I mean, talking about practice, well, basically you look at the flow first. Mm-hmm. And then you look at the size of this dissection. When I say size, I mean the length of course, and if it's radial, spiral, or is it just a tear. So we got, as you know, many classifications, many ways to, let's say, describe a dissection. But I mean, as a matter of fact, if the flow is still TIMI3 flow, I mean, it's a, let's say, benign condition. However, you need to consider what is the possible, or let's say, evolution of this dissection. So in my practice, when I see a short dissection in the range of few millimeters with no flow limiting situation, I'm happy to leave it. Nevertheless, you need, well, what I typically do is to evaluate every time I have a doubt with imaging. But of course, you cannot link the imaging to the use of DCB, otherwise it would never work. So in other words, angiographically, look at the flow, look at the length of the dissection, and then make a decision based on your experience. And also, just remember that the DCB is not against DES. They are complementary. So if you are in doubt, just put a DES.
Okay. So I think we're making that point, and we will see another case and see these cases where DCB is not yes or no strategy, but part of the bigger strategy. And I think that makes an awful lot of sense. Let's talk a little bit about preparation tools. We had 2 sessions before on instant restenosis and native vessels, and the cutting balloon was in there quite a bit, whereas in your cases I didn't see that so much. How important is the use of a cutting balloon as opposed to just simple predilation? Sandeep?
So for me, the lesion preparation always starts with a 1-to-1 NC balloon.
1-to-1 NC balloon.
1 to the vessel to artery ratio.
Yeah,
and I leave the balloon for at least 30 seconds. By doing this, I'm achieving 2 things. One, ischemic conditioning. So when you inflate the DCB longer, patient tolerates better. And then it gives me a less recoil. After this, I take a picture. If there is a recoil, then clearly I have to go with a specialized balloon. So I tend to go with a cutting balloon. But before that, I use an intravascular ultrasound because I want to understand what's making the recoil. If it's a calcific, I got a low threshold for taking cutting or an IVL. If it's a fibrotic, then I go for scoring balloon. And if I get a good result with that, then I go for a DCB. But if I have a good expansion, if there's no recoil, there is no evidence to support a routine use of scoring balloon before a DCB if you have a lesion preparation with the NC balloon.
Okay. There is a question here on the use in bifurcations. In case of simultaneous kissing balloon inflations, DCB in both or only in one?
Well, a good question. Again, as a matter of fact, well, what you are treating in that case is the side branch. So, or at least in theory, there's no need to use a DCB into a DES that you just placed, at least in theory. So, or just remember that a kissing balloon is meant to treat the ostium and to make sure that you are delivering the drug into the side branch. So I would say also in terms of, well, budget and finance, you don't need to use a DCB into the DES that you just placed. So let's use normal balloon in the main, DCB in the side branch, and then of course just close with a POT as usual.
Okay, we've seen the results, or you mentioned the results of the REC cage-free trial. I think at this stage we need to mention that there are different balloons and different techniques, Sandeep. Are all DCB the same? The question here comes as well. Sirolimus or paclitaxel, what do you use? Can you comment on that?
I mean, with the paclitaxel, probably I would say it may be more or less similar because of the drug itself is quite effective in the artery. Sirolimus, we have to see the clinical outcomes of all the other 4 technology which you showed earlier. But for me, like the data is very strong towards paclitaxel in the literature. So we use paclitaxel in almost 50 to 60% of cases, and we use sirolimus in sort of 30 to 40% of cases in selected scenarios.
Okay, so you select.
Yeah. So for example, if I'm using a DCB in a STEMI, I tend to use sirolimus more than paclitaxel because I've seen some slow flow from a particulate embolization, and patients have kind of had hemodynamic compromise. So I tend to use more sirolimus.
Okay. STEMI indications, we move on. One of the indications you mentioned, and I asked Luca that question, is high bleeding risk patients. And that brings us to the question, what is actually the mandatory antiplatelet strategy following, let's say, a straightforward DCB application, no stent involved?
Well, obviously there are a couple of layers to this question. The first is, according to the data again, and or even the previous version of the guidelines were just supporting the idea of treating a drug-coated balloon, likewise a DES. So in terms of the clinical scenario, 6 months, 12 months. But what I'm doing, that's my practice, I tend to minimize the duration of dual antiplatelet therapy, and at least I would say I keep it for 2 weeks. And obviously I have no data to show you, but definitely I can tell that it's honestly potentially a game-changing approach, because especially in cases where you have atrial fibrillation, indication to oral anticoagulation, elderly patients, so typically the high bleeding risk patients we see every day, the opportunity to have a procedure linked to a very short dual antiplatelet therapy is honestly very, very intriguing. But that's what I'm doing. 2 weeks, and so far, so good.
Sandeep?
So I use, if it's a non-complex, not a high bleeding risk patient, I give up to 3 months in a young patient. But high bleeding patients, as Luca said, I usually give for 2 weeks. And then, so we had a patient who had a bowel cancer. So we gave 2 weeks of DAPT, and she had a surgery 3rd week. So she did very well, proximal LAD.
But that is assuming the lesion is stable, and you have probably a stent-like result to start with, right?
Yeah, I mean, of course, if you're happy with the DCB result, like to 30% recall, for me, it doesn't matter the duration of DAPT. ACS, of course, I tend to leave it for a year, even if I use DCB. But
that's the
stable
presentation
angina
that determines the duration of the... Now, a trick question. If you had a long distal LAD, as you showed, that used to be the domain of scaffolds. Leave nothing behind, leave way for surgery later. If you had the choice in a long diffuse distal LAD and you had a scaffold available, what would be your differential approach? Which one would you choose first, DCBs or scaffolds?
Well,
Luca.
Okay, in taking this question, I would say that, the history of scaffolds have been, let's say, conditioned by the problem of lesion preparation and stent thrombosis, well, scaffold thrombosis, at least theoretically. However, to answer to the question, I would say that given the fact that our experience with the BVS, with the scaffolds, didn't go so well, I would go for a DCB, but I would try at least to maximize the lesion preparation in order to minimize events at the follow-up. So my answer to your question is DCB.
DCB, okay. And final question before we go to the 2 really great cases for Sandeep. Tell us how you handle the balloon. Is there, it used to be you're not supposed to touch it, you can only use it once, you leave it up for 60 seconds. Talk us through how you do it.
You made a very good point. So the most important is not to activate the balloon outside.
Activate.
So not to touch. So I try not to touch the balloon part, even if it's a long balloon. And once you're in the circulation, most of the companies say that you have to deliver within 2 minutes. So obviously you have to make sure that you have a good guide support, maybe a guide liner or buddy wire. So if you can't deliver within 2 minutes, you cannot reuse it. So you have to take it out and you have to discard it. So for all the companies have recommended that you cannot reuse the balloon if you're not able to deliver within 2 minutes. Now, inflation, I tend to leave for at least 60 seconds, sometimes even 90 or 2 minutes, because as I said earlier, because I leave my preparatory balloon longer, they get ischemically conditioned, so I can easily for 2 minutes or 90 seconds. So I'll never use 45 seconds unless I'm doing in left main, which is very extremely unlikely. Then I have to do 2-step inflation. But for me, I'll leave for at least 60 seconds, maybe 2 minutes. But what I'm looking at is not the ECG changes. I'm sure you'll have ECG changes. Patient will have some chest pain. I'm looking at the blood pressure. If the blood pressure is stable, I'll leave the balloon as long as I can.
Okay. Final question to Luca. Is it okay to post-dilate after you have delivered the drug?
Well,
there could be a squeezing effect there.
Well, at least in theory, the very last thing that you are supposed to do is to use the DCB.
Yeah.
Because we don't have any clue about what is going to happen if you touch that endothelium more after the DCB deployment. So I would say try not to use a non-compliant balloon or post-dilatation anyhow, because the DCB has to be treated as a carrier, a way to deliver the drug, not a balloon to do the angioplasty. So in other words, all the preparation, all the dilatation must be done before the DCB usage and deployment. So DCB has to be the last thing you do.
That's pretty clear. So we've got lesion preparation, we've got how to handle the balloon, and the DCB is definitely the last bit, even if it's a very, very complex procedure. Last bit that goes in is the drug-coated balloon. Time for another two cases. Luca first, with a case example from Milan.
All right. So, well, I'll try to be brief because the story is a bit complicated, as you can imagine. So I'm talking about a 68-year-old gentleman, diabetic, with a previous CABG in 2018, with a lima to the LAD, a vein graft with a couple of jumps to D1, D2 and ramus, and another vein to the PDA of the RCA. Normal ejection fraction, well, slightly reduced, renal function, no valve disease at all. From 2020 to 2023, 3 PCIs to the vein graft, to the D1, D2 and ramus, and 1 PCI to left main LCX and ramus. It came to my attention in November 2023 with a relapsing effort angina, and that was the situation, as you can see. The SVG for the PDA was patent, no critical stenosis of a native PDA, and actually I checked with the previous angios given by the patient, was basically the same. But then the vein to the D1 ramus actually showed an additional ISR in the mid-segment, and there were no critical stenosis of the native vessels. So this, as you can see, there is a kind of full metal jacket of vein made before. And then lima to the LAD was patent, no critical stenosis of a distal LAD, and some ISR to left main LCX. So I decided to go for the hardest way, so PCI, left main, LCX, and ramus. So initially I basically treated the ISR with multiple balloons, including cutting, and then I tried anti-gradally to place a wire into the ramus, because as you can see in that ramus, there's a stent already placed in the previous procedure. So it was really impossible. And then I decided to go the other way. After ballooning a little bit the vein graft, which was not my target at that time, I actually decided to go retrogradally, and with a Gaia 3 guide wire, I managed to achieve a true-to-true recanalization, and actually I closed the circuit by crossing into the left main and then into the guiding catheter. So this let's say that then I used multiple balloons, up increasing size, non-compliant balloons, in order to open the struts and prepare the stent, which I treated with a DCB 3x16 to achieve a good result. And then I was, of course, to make sure everything was fine, or in the case that I needed more aggressive preparation, the stent was very well opposed. And then I did, in this case, a kissing balloon with 2 DCBs, and this is because there was ISR in the main and ISR in the side. And then I closed the case with a POT to the left main as usual. But then 2 5x30 DCB to the ramus for, I would say, an acceptable, good, final results. I was happy at that time, but after 8 months, again, relapsing effort angina, so immediate coronary angio showing completely blocked ramus again, and a new ISR in SVG. So for this case, I decided to go for the easy way, and then multiple predilatation with NC, balloons of increasing size, up to 3.5 for the SVG and 4 for the left main, followed by 2 DCBs, different from the previous procedure. The first procedure has been done with sirolimus-based DCB, This one has been done with paclitaxel, the DCB. That was the final result. Again, I was happy, especially considering the SVG was honestly very nice. But then, what I can say is that after 5 months, the patient is doing very well. But definitely, at least in my practice, the use of multiple layers of DS seems unreasonable in some anatomical situations, as they seem inevitably prone to failure. The use of different formulation DCB may have a rationale in case of failure of a DCB, but no supporting evidence. Imaging is never enough, but because it will help you, it will guide you, it will definitely give you information that you need. Thank you very much for that.
Great case. Fantastic case. So let's talk about these layers, because in-stent restenosis is an FDA indication in the US, because the trial there was done not against drug-eluting stents, which have no indication for in-stent restenosis, so they didn't have that comparator. Here there is one trial, I think, where it's not entirely clear who's winning. But the idea of having 2 or 3 or 4 stent layers intuitively makes you uncomfortable, right? So Sandeep, in-stent restenosis is our indication, isn't it? And when do you choose the drug-coated balloon? Is it the first in-stent restenosis, the second, the third? You know.
So for me, if I have an ISR, no matter how many layers of stents are there, I want to avoid another layer of stents. Mm-hmm. So for me, the way I look at it is DCB failure is forgiving. So even if it fails, like as in Luca's case, he went back with a different balloon. Whereas if the stent fails, then you're stuck because you already have 2 layers of stents. So for me, I still strongly use DCB in ISR, irrespective of the mechanism of the ISR. Even if it's neoatherosclerosis, if I have a good lesion preparation, I still go for DCB.
Yeah. Okay. So as a reminder, we have a full session on in-stent restenosis, and it's online. Luca, I just want to clarify one thing. Initially, you said we can't combine or marry DCBs and imaging because that would be too complex. But in in-stent restenosis, that is a given. We need IVUS OCT for in-stent restenosis. Please confirm that.
Thanks for the question, because it gives me the opportunity to clarify that for ISR, the use of imaging should be mandatory because it gives you information in terms of the mechanisms behind the ISR, which can be either, well, let's say based on, well, let's say a bad technical thing done during the first procedure, or just neoatherosclerosis, or just because of systemic conditions. Nevertheless, for ISR, we should be using imaging most of the cases. I would say 100%, but I know that it's not practical. For native vessels, I believe that linking the DCB, which is an expensive device, with the use of IVUS, especially in some countries, will not be practical because it's not going to happen. So ISR, we also have the guidelines supporting this, so just use it. For native vessels, either small or large vessels, just try not to use. However, if you are building your practice, if you are building your confidence, I suggest that you do it because you will understand which type, for example, which type of dissection you can live in or you cannot. So building up your experience, your program, use it. But again, for ISR you have to. For native vessels, completely different animal.
Now here comes an expert advice. Bruno Scheller comments, he advises against kissing drug-coated balloons because of 2 reasons. First, the DCB is too long in blood, and second, only a minority of balloon surface has contact to the vessel wall. Direct reply?
Well, yeah. Well, definitely, I would say, I totally agree when you are doing, let's say, a bifurcation. So, sure, don't need DCB in the main because you put a stent already. So, combining DS, a fresh DS plus a DCB, I honestly don't see the rationale. But in the cases I showed, there was ISR both ways, left main, LCX, and Ramos. So I think that there was a kind of a rationale. Don't ask me for the data because I don't have it. Yeah. But then I think that it made sense to, let's say, deliver the drug both ways.
Okay, let's see the next one. Sandeep, very challenging case to...
Okay, so my case, I would like to show how we evolved our practice in PCI. So I would like to take you back to 2014 when I was appointed as a consultant in my hospital in Birmingham. And I came across a 58-year-old man with angina and heavy smoker, diabetic, CKD, so all the recipe for stent failure. So he had an angiogram. The stent in the proximal LAD was patent, but he had a large ischemia in the LAD territory, and the LAD was diffusely deceased. So what I did, I put a stent from all the way from top to the bottom, so a full metal jacket in November 2014. Now this was, I was guided, procedure was done well, but patient was okay for 2 years, and then he came back with angina. Then I started seeing the problem. So the distal LAD was blocked off, and you could start seeing some restenosis. So we treated this, and again, he was okay for 1 year, and then he came back again. Now this time the stent is completely blocked off. Since then, he has had 2 or 3 procedures where we try to open the artery, it remains open for a few months, and then closes off. And in 2023, he has now developed severely impaired LV function. He's got ischemic cardiomyopathy. He has got ICD. So he's not doing well. So 9 years, he had a very rough course. And I regret this technique, what I did. But this was the normal practice at the time. Now let's move on to 2021. So this is post-pandemic or during pandemic. So we came across a lady, a 75-year-old, end-STEMI, same risk factors. In fact, she is on hemodialysis, end-stage renal failure, diabetic on insulin. She had PCI to RCA, which was the culprit, but then she came back for a stage PCI to LAD. And look at this LAD. Of course, there's a calcified nodule in the ostium of the LAD, but the whole LAD is diffusely deceased. So this is the lesion we were trying to treat. So obviously, we started trying to understand the calcium, but they were unable to pass the IVUS probe. So we ended up performing a rotational atherectomy, several runs, and this is a post-rotablation, so it doesn't look great. So we performed an intravascular ultrasound, but we had achieved a lot of cracks. You could see there's a lot of cracks in the calcium. So then we went with an NC balloon, so aggressive pre-dilatation all through the LAD to the proximal segment, into the left main, and then we repeated the intravascular imaging, more cracks. So balloons were expanding, so it was time to treat. So what do we do? Where do you start and where do you stop? So in like last case, I could have done a full metal jacket, and we know here, small stent, renal failure, diabetes, it's a recipe for restenosis. So we decided to go for a hybrid strategy. So we used 2 long DCBs in the mid and proximal LAD, and we used a long stent from left main into the LAD, and we optimized with the higher balloons in the left main, and we did an IVUS of the stented segment, and we had a good MSA of more than 8 mm square with well-opposed stent struts. So this was the final result. Now, as I said, the DCB segment doesn't look great. It's got a lot of some recoil, dissection, but I'm looking at the flow, the STEMI3 flow, and I don't want to place any more stent. So I stopped here, and I wanted her to come back for a check angiogram at 6 months. She agreed, but the problem was a pandemic, so we had a lot of logistic issues, and she came back 18 months later, completely asymptomatic. She had no symptoms of chest pain. So we did the angiogram. We were amazed. The distal mid-LAD looks remodeled. Yes, there is some recoil in the mid-segment, but she's asymptomatic, so I had no reason to go and do anything. So she had a clinical follow-up this year, mid-2024, and she completely remains asymptomatic. So 3 years since the procedure, she has not had an event, and I'm very proud that I used only 1 stent and rest DCB. So for me, DCB, again, I want to reinforce this, that it should be the first choice in diffuse small vessel disease. And the aim of DCB angioplasty is to minimize the stent length and to avoid stents when they're not desired. And hybrid approach should be considered strongly, especially LAD and RCA when you're trying to avoid stenting the PDA. And of course, as I showed earlier, we shouldn't be avoiding. We should be avoiding swing.
Bring that back just to remind ourselves what we don't want to see.
Yeah. So here we don't need a contrast to say which artery have been stented. So
those were the days. No. Okay. Thank you. You can move forward, I think.
Thanks.
Thank you so much. Questions are coming in. I've got 2 questions about your case now. The first one is you brought the patient back for a routine check angio.
You mean the first patient?
The last patient.
The last patient, yes. So
what makes you decide to say, okay, I don't want to do a CT, I don't want to just do ischemia testing. I want an angiogram to see how it is.
I think it was a kind of mutual agreement with the patient because I explained to her, look, I have not put stents here. I've done something very unusual with hybrid and would like to see. And she, in fact, wanted to, keen to have her, results checked. So it was mutual agreement, but because of the logistic issue, in fact, I'm glad it was 18 months because we got a longer angiographic follow-up, and it was great. But I don't do routinely in my practice.
And the second, about this angiogram, when we looked at that before the webinar, actually, you said the vessel had grown a little. That's something we associate with the scuffles again, and definitely not with stenting. Stented vessels don't grow. So how often do you actually see that phenomenon? Luca, can you?
Well, this phenomenon, this late lumen gain, is something that we have seen since the beginning of the experience with the DCB, and apparently is much more related to the use of paclitaxel-based technologies. And according to the pathologists, this phenomenon is a consequence of the toxic reaction of the tissue with the paclitaxel. It doesn't happen so often with the sirolimus. So actually, I'm not doing the coronary angio follow-up for all the patients. I'm using the CT scan in the majority of the cases because it's not invasive. So all those things. But definitely, when you are using a paclitaxel-based technology, you can expect this phenomenon to occur. With sirolimus, is less frequent, I would say. And obviously, it's a very good thing to see because it gives you really the chance to understand that you have done a good job without caging the artery. So I see a lot of potential in that terms. And even from the literature, we have this information. I mean, the late lumen gain is something real, and it occurs more frequently with paclitaxel.
Okay. Brings us to a very, very important question, which we haven't addressed at all so far. We've always spoken about effectiveness, efficacy. But are there any safety concerns? What's the safety profile of drug-coated balloon angioplasty? And I'll just formulate it even stronger. Some of us would be afraid if we left dissections alone that patients would have early vessel closure, acute events, early restenosis. Sandeep, and then I think both of you should answer that question. What's your view on the safety profile of this technology?
I think there are two safety views. One, look at the hard endpoints like cardiac death and TVMI, and most of the DCBs are safe in that front. TLR can happen, so DCB can fail. So if you have a TLR, which is restenosis, can happen with any DCBs. Whereas with the acute closure, in the entire almost like 9 years of my DCB practice, I had only one case of acute vessel closure.
When did that happen?
This happened in 2016.
Time
within 24 hours. So it was in the same index admission. But since then, I've not had any acute vessel closure. So for me, I'm leaving more and more dissection now. Of course, I evaluate in multiple views, make sure there's no dye hang-up and flow is STIMI3. And if I'm happy with that, I tend to leave the dissection. And we are more comfortable leaving dissections now what we were, let's say, going back 8 years ago.
Luca?
Well, one thing, I think we should be actually distinguishing two different layers. I mean, I've never seen a case of acute closure and thrombosis, but I have to say, I will also say we are kind of obsessed with dual antibladder therapy just to make sure that the platelets are inhibited. So that's the first thing. Second thing is, what I'm trying to do, at least in my practice, when I'm treating a very long disease with soft plaque, I try to reduce the duration of the inflation in order to minimize the risk of distal embolization, which is probably the only remaining issue that we need to consider, because ultimately we're inflating a balloon. So the more you take care of the inflation, if you keep it very long, obviously you increase the chances of having a distal embolization. So, as Sandeep mentioned before, there's no concern in terms of other endpoints at all. But definitely in terms of what we can immediately have, I would suggest just try to understand which type of lesion you are dealing with, and then you can adjust your technique accordingly.
Thank you. I've got two more questions which we should answer because they come from our audience. Not related to what we've spoken just now. Is drug absorption normal in a STEMI, especially with clots? That comes from Usha Rao. Luca, you're doing STEMIs.
Well, I'm not doing DCBs in STEMIs because I honestly have no information concerning the real absorption of the drug when the arterial wall is inflamed or in the presence of thrombus. So I'm not using it.
That was a clear answer. Are you using it?
I use it again. It's not like I still predominantly use stents, but if I have a very ectatic artery, small vessels, I still use it. But I have to say that I use a lot of thrombus aspiration. I use GP2B3A for at least 12 hours, sometimes even 24 hours in a younger patient, and then I use DCB, and we have had some great results.
Okay, so the jury is out. Are there trials coming? At least one in STEMIs?
I think there's one ongoing in Spain where they're comparing a DCB with stents in STEMI all-comers.
I think Bernardo Cortese has one as well.
Yeah.
Good. And then this Goran Kovic asks a simple question: do you put the DCB in negative before inserting and deploying it?
Well, yes, I personally do
just
it.
Like a normal balloon?
Yeah. Once I've deployed, I just make it negative and take it out.
My final question for both of you is, you're not working in isolation. You've got a team around you, and I assume others will do the same. How do you train and educate, and how do you keep abreast of these developments, Luca and then Sandeep?
Well,
in Italy, is there a training program? Do you need to get certified? Do you,
Oh, not really. I mean, there's no specific certification or, let's say, degree in terms of, let's say, mastering the technique of DCBs. But what I try, at least, to deliver, especially for the young colleagues, that it's a mindset. It's a mindset requiring careful lesion preparation. So placing a stent can be really forgiving as long as you carefully prepare the lesion. But also if, for example, the stent is not expanded or something, you can post-dilate. There are multiple things that you can do. But with a DCB, if you create a big dissection, you have to place a stent. So in other words, if the initial strategy is to use a DCB, just go for, let's say, a more careful lesion preparation, and always consider that if this preparation fails, you got big dissection, you have problems, just place a stent. Don't stick to one plan. You must have a plan B.
Sandeep, how do we train in England?
So here in England, obviously, we have lots of workshops. I proctor, and we do a lot of symposiums. We arranged one in Birmingham. Of course, this symposium is great. So all these technical tips and tricks will train the operators. And as I said, the mindset is what people have to be open about. And again, I would, in the initial phase, recommend taking on some simple cases rather than taking complex cases, and then try to check your, bring the patient back if you can, check the angiogram result. And for me, most important is that you have to witness the success of a DCB clinically or angiographically. That will give you more confidence, then you can embark more complex lesions. That's my advice.
Thank you. And that brings us to the end of number one. We looked into practice in 2 countries in Europe, probably representative for expert users, also in other parts of Europe. There will be a second part looking into practice in Asia, and Bernardo Cortese will come. He's of course, in Italy and the United States of America. He will show us what's going on up there and his thoughts. So I think, to summarize, we've went through the practical application, and we went through the practice of 2 users that are very, very comfortable with the technology and have a lot of experience now accumulated with the technology. We've established this is not according to guidelines because there's simply not enough evidence to make it into the guidelines, but it is practice and there is experience with good clinical outcomes. We've established the safety profile is perfectly okay. It is safe to use these tools. We've established there is need for proper technique, for proper preparation, intravascular imaging when needed, particularly in instant restenosis. And I think also the mindset to have this not as a needed tool and you can only use this or something else, but to have it as part of a greater strategy, and also including hybrid procedures where stents and drug-coated balloons live in harmony next to each other. With that, we close. Thank you both, and thank you for the audience, and I hope it was interesting and informative.
Yeah, it's a great pleasure. Thank you so much for the invitation.
Goodbye.
Thank you very much.
Thank you. Thank you.
Thank you very much.